Good morning, everyone. My name is Christopher Dickton, and I'm the Deputy Director in the Division of State and Community Health. I'd like to welcome all of you to what we've traditionally called the skill building session, but we thought we'd go a little more Garrison Keeler on this and call it a conversation with Tish on the Title V MCH Block Grant. So we've got a lot of things we're going to cover today, and I'm just so excited to be here. I have to tell you, I've always been very self-conscious of my smile. So if you see me smile, it's always like this. And it's not, I just don't like my teeth. But I've been doing this the whole time because it's been so long since we've all been together. I mean, relationships have been developed over time virtually. And I cannot tell you the intimacy I feel with some people I've never met. You know, you go up and you're hugging people and you're like, I don't think I've ever met you. But I think one of the things that's really important is we're having this time to reconnect and rebuild, find our common values, look at that federal-state partnership in a really practical way, and just continue to make an impact for the moms, kids, and families of our nation. So with that, a couple housekeeping things. The slides that you're going to see today will be available. We'll be sending them out after the session. One of the things is that there will be time for Q&A after each session. So hold your questions or write them down, or and we'll be able to go through those. The other thing too is we're really lucky with these two rooms. If you just go out, the bathrooms are right there. So one of the things that I think is really important is that we're going to be together for quite a few hours. If you feel like you have to stretch and stand up and move around, if it's not part of the Q&A, we won't think you're asking a question, but feel free to stretch. Also, you know, if you have any questions after this, you always have your project officers to reach out to and talk through any kind of worries or concerns. You've got Shirley, you've got me, you've got Ellen and Nora as well as the leadership of the division. So we're always here to help support you. Before we get going though, let's do something. How long have you been with Title V? Let's start this exercise stretching thing. So if you've been with Title V working in the program in 1 to 2 years, stand up for a moment if you would. Oh, come on, don't be shy. Yes, welcome. So let's go if you've been 3 to 4 years. In other words, let's say you worked on the needs assessment in 20. Okay, now we're going back 5 years, five to 10 years. Anyone? Oh. All right. More than 10. Come on. Oh. You know, one of the things that's really important is when you look around and see that, you see that there's this legacy of knowledge. There's information that can be passed on, part of mentorship, part of growing. You have a lot of people still here who've been around for a while and have been through things that can share their wisdom. Don't hesitate as you're growing in your role to ask questions, to reach out, make connections this week. This is such a vital time since we can all be together again to reconnect and reestablish those relationships and friendships. It's amazing how it is when you go up to someone and say, I don't know this, I don't understand it, can you help me? And you get that help. So it's those partnerships that are so key. I was reflecting coming back and smiling a lot. But what it was I presented at this session for the first time in 2001. But it's over 20 years that I've been kind of standing in front of you guys and saying things. So, I mean, I know. just reminded me of the importance of this time together and this connection, you know, that to have this time to really think through. And I think one of the things that is really key today is we are going to be talking a bit about the guidance, the revised guidance that's coming out. If you haven't been reading your emails, yesterday the Federal Register notice was published for the 60-day comment period on the revised guidance. This is it. Yes. Timing is everything, right? You know, the fact that we're going to be talking about it here, and we weren't quite sure when it was going to finally drop. But please look at that, the email that came out on the listserv. It gives you the instructions for how to request a copy of that guidance to review. Please review this one. Please review. There's so much in it that is a bit different, and it built on the listening sessions from last year. We're going to get into that a bit more. So we're going to talk about that. But before we get going, I'd like to welcome our Deputy Associate Administrator, Laura Kavanaugh, to provide some welcoming remarks for us. So Laura, I give it to you.
It is such a joy to be here in person with all of you today. Good morning. Good morning. And it's also wonderful to see the breadth of knowledge that we have in the room, some with more recent expertise in Title V and some with longstanding expertise. I'm one of the long timers. I've been working in Title V since it's a while ago. Federal government since 2001. Federal government since 2001. So it's such a delight to be with you today. As Chris mentioned, I'm Laura Kavanaugh. I'm the Deputy Associate Administrator for the Maternal and Child Health Bureau. I send regrets from Dr. Warren. He's not able to join us today. He is preparing for congressional testimony on maternal health. Trust me, he would rather be with you. He would rather be with you. He sends his regards. I want to provide a little bit of background about the Bureau for those of you who might be new to Title V. Talk about a number of the areas that we have up for competition. We have a number of things that are, and I'll go into greater detail tomorrow during the plenary session as well. And then I have the great pleasure of introducing our two newest division directors within the Maternal and Child Health Bureau, who we actively recruited from your midst. So a little bit of background about the Bureau. Our mission is to improve the health and well-being of America's mothers, children, and families. We want to make sure that we envision an America where all mothers, children, and families thrive and they reach their full potential. We work with to improve public health by funding national, state, and community organizations and academic institutions as well. We partner to develop innovative programs, expand the MCH workforce, create maternal and child health leaders, and strengthen data and research for MCH populations. As you all are very well aware, we take a life course approach to our work, and we look across the lifespan. In the Bureau, we're using a strategic plan to guide our efforts for the next 10 to 15 years. Because our grant cycles tend to run in 3 or 5 year cycles, we want to impact the future in the long term. So we wanted to have a longer vision and a strategic plan that would take us into the future. Our plan highlights 4 goals around access, equity, workforce capacity, and impact. And all of them, are essential for moving our vision forward. Before we get to the rest of our agenda, I'd like to take a moment to highlight the many funding opportunities that are currently available to you. I'll provide, as I said earlier, more detail tomorrow at the plenary session, but you can look at grants.gov. In addition to the block grant guidance that is available, there are a number of competitions available for you. And now I'm pleased to introduce our first 2 speakers. And as I think I mentioned this before, I'm so thrilled that they are here. First, I'm pleased to introduce Dr. Shirley Payne. She's our director of our Division of State and Community Health. Oh, please do. In her previous role as the Assistant Commissioner of Public Health Protection within the Indiana Department of Health, Dr. Payne provided essential leadership to 6 divisions during the COVID-19 pandemic. Her crucial work was recognized when she was named the Public Health Hero by the Indiana Public Health Association earlier this year. Prior to serving as the Assistant Commissioner, Dr. Payne was the Division Director for Indiana's Children's Special Health Care Services Division. In this role, she managed the children and youth with special health care needs portions of Indiana's Title V program and Indiana State Supplemental Coverage Program. During this time, she also served as interim MCH director twice, which gave her additional opportunities to lead multidisciplinary and diverse teams. In 2019, Dr. Payne received MCHB's Director Award for all of her work of her career. Dr. Payne is also former president of the Association of Maternal and Child Health Programs Board of Directors. She holds a doctorate in health behavior from Indiana University School of Public Health and serves as an adjunct professor for that university. As a director of DISH, she's overseeing MCHB's largest program, the Title V Block Grant, along with other critical programs that serve the maternal and child health population. In 2020, an estimated 60 million people benefited from a service supported by the state block grant. 93% of all pregnant women, 98% of all infants, and 60% of children, including children with special health care needs. Please give yourselves a round of applause for that. It's quite remarkable. We're incredibly grateful that Dr. Payne has come to us with her expertise and leadership, and we look forward to see her continue to bloom and lead DISH as this important work of both decreasing disparities and improving equity advances in states and communities. So welcome, Shirley. We're so happy to have you. So next I'll introduce I'll introduce both of you, sorry. I'm just throwing things out. And then I'll turn it over to Shirley. Is that okay? Okay. I'm also pleased to introduce our new director for the Division of Services for Children with Special Health Needs, Dr. Jeff Brosco. Dr. Brosco is a historian and a physician who teaches and practices general pediatrics and developmental behavioral pediatrics at the University of Miami's Miller School of Medicine. At the University of Miami, Dr. Brosco serves as the Associate Chair of Population Health for the Department of Pediatrics. He was also the Director of Population Health Ethics at UM's Institute for Bioethics and Health Policy. His research focuses on history, policy, and ethics regarding child health. It's a wonderful combination. If you haven't read his papers, they're a wonderful combination of those 3 things. He's authored 50 peer-reviewed publications and over 90 other publications. From 2010 to 2022, I think this is where we originally met, he oversaw the MCHB-funded Leadership Education and Neurodevelopmental Disabilities Training Program at the Mailman Center for Child Development. As a grant recipient, Dr. Brosco gained firsthand expertise and knowledge of MCHB and our mission. For more than 2 decades, Dr. Brosco has held a series of leadership positions for the Florida Department of Health's Children's Medical Services, which seeks to improve the health of children with special health care needs. From 2017 to 2019, he was the Deputy Secretary of Health for CMS. From 2018 to 22, he was the state's Title V Director for Children with Special Health Care Needs. So both of them come from your midst. Dr. Brosco has also been active in national health policy groups. And in 2019, there's a common theme here. In 2019, Dr. Brosco was awarded an MCHB Director's Award for his work as well. As the Director of Children with Special Health Needs, Dr. Brosco will provide leadership and guidance to support the estimated 13.5 million children in this country with a special health care need. I want to talk a little bit about the Children with Special Health Needs programs within the Bureau, in case you're not as familiar with those as well, because these are the activities that Dr. Brosco now oversees. So our newborn screening program reaches 4 million newborns that are screened every year. Our sickle cell program serves about 25% of individuals with sickle cell disease in the United States. And our family-to-family health information centers work in 59 states, territories, and Indian tribes to provide critical support for families of kids with special health care needs, particularly families of children with complex needs and those from diverse communities. We also coordinate the Advisory Committee on Heritable Disorders in Newborns and Children, and that group advises the Secretary of the Department of Health and Human Services on the application of universal newborn screening tests, technologies, policies, guidelines, and standards. We're sure that our nation's children and youth with special health needs will benefit from Dr. Brosco's expertise and the continued great work that Dr. Brosco will lead. So please join me in welcoming Dr. Brosco. The last thing I'd like to do before turning it over to Shirley is just remind you that we'll have a series of listening sessions tomorrow and Tuesday. And we've organized them by region, but if that time doesn't work for you, for your scheduled region, come anytime that you would like. We'd love to see you. Sometimes people come back more than once because they just can't get enough. So with that, it's my pleasure to turn it over to Shirley.
Thank you so much, Laura. And I told my team, I was like, I'm taking these heels off. I need the flats. I may not make it down those stairs up and down, but it is so good to see you all. Oh my goodness. I was talking to Kathy Caldwell, and we were just talking about, I hope that this meeting, I know you've probably attended some additional in-person meetings already, but a lot of what we've done, especially conference-wise, has been on Zoom. So I hope this gives you this new level of excitement. It's kind of like this kickoff of being able to really network with one another, see each other in person, talk to the people that you don't always get to talk to, definitely putting faces with names. I've seen some people, oh, your hair's grown out or you cut your hair. So we just really hope that this is an opportunity for you to be able to have that excitement and also enjoy this weather. I know in Indiana and in Maryland, we were in the 50s. So I think that this is great. Got out the airport, I was like, I am sweating. So again, enjoy this opportunity. I could not be more grateful to Dr. Warren and Laura and the DISH team for allowing me to be here. It has been such an honor being with this team. Sorry. Thank you. Appreciate you, Aaron. Aaron keeps me together. It's 7 months, Jeff. We're 7 months in, and it feels like that time has flown. I feel like I've grown so much, but there's still yet so much that I do not know. So I appreciate the grace. So the one thing that we talk about all the time, and I'll always push, is just grace. I said, Dr. Warren and Laura say it to me all the time. We say it as a team. Please say it to one another. We just need the grace to learn. And when you don't get it right, they lovingly correct you and to correct you, and they give you the education behind it. Oh yeah, I've been saying that wrong. So just make sure you're giving each other grace in that aspect as well. As I think about, Title V and just the longstanding history that we have and what we've been doing, our division, much like you, has a range of folks that have been there. I said, we've got some new staff that are coming, but I'm one of the newest. I think I see Louis, I see you back there. And so we're some of the newest on the team, but with Title V being the staple that it is, our job is to continue to protect that and to continue to make sure that we are able to put things, just like we're going to talk about the guidance today, that's going to really help you do your work in your state, giving you that ultimate flexibility. And that's where we want to be, because one of our biggest pieces and one of our goals is always going to be around visibility. Because the reality is that, we still go to meetings now ourselves with some of our federal partners. I'm sure some of you step in a room and people have no idea what Title V is, or they think they know, or they think it's Medicaid, or is this home visiting? Is this what this does? So I think one of our main responsibilities on our end is making sure that we put that out there. And with that comes partnership. And so for us, I know being on the state level, you'd be like, well, can the feds, I'll just say feds, because that's what we would say. So, can they help us figure out how to partner with Medicaid? Can you help us figure out how to partner with, childcare folks? And what we see too is sometimes it can be difficult on our end too, to figure out the right people to get in touch with, and making sure that we're doing that. So that's our commitment as well, is making sure what we're asking you to do on the state level is the same that what we're doing. And so we are working very, very hard at that. And then I think one thing you will hear Jeff talk a lot about in this session, then also if you're going to the SHIN session this afternoon, is data and measurement. How are we measuring what matters? And are we capturing that? Because we certainly see that we are making a lot of improvement with our performance measures, but there's some that we want to improve as well. So you will hear Ashley and you will hear Carrie Ann talk a lot about that today as well. But how are we doing that to make sure that we're truly capturing what it is that we see? And also what the Title V programs, we know who we see, but who are the people we don't see that we still need to figure out how are we reaching and how are we capturing that? So we've got a lot to still do. We've certainly come a long way. We think that, you'll hear more about the guidance later. We are really excited about this guidance, but I will stop there and let Jeff say a few words because I could keep talking all day.
It is so great to be back with so many friends. And I think one of the things that's so important for Shirley and me is that we used to sit where you are. So we are deeply connected in that way. I'm going to keep my remarks really short right now because I know I'm all that stands between you and the guidance and performance measures. I'm sure you're eager to get there. But before I do, if you had, for this to work well, our divisions, Shirley's and mine, have to work well together. Can you imagine a better person to work with than Shirley Payne in the entire world? We started on the same day, and we have such a great time together. Wonderful partnership we have in our divisions. I am going to have a chance to talk to you afterwards about the blueprint. I'm sure the blueprint for how many of you about a year ago, the blueprint for children with special healthcare needs came out, a bunch of papers in pediatrics about where we want to go. How many of you, just by show of hands, have seen it, heard about it? You talked about it already? Okay, excellent. And how many of you said MCHP wants us to do something else? If I were sitting where you are, I would be feeling the same way. So just three quick things. The first thing is, it is entirely consistent with Maternal Child Health Bureau strategic plan. It's not different. It's entirely consistent with the guidance. You're going to hear about that in a few minutes. And the third thing I want you to hear, we'll talk about this more when I come up, and especially this afternoon, it is designed to help you do the things you're already doing, perhaps with a bit more impact. But it's not asking you to do things new. It's asking you to do things that have an impact. Thank you.
Okay, Aaron, let's see if I can manage this by myself. All right. So we got that. All right, so now what we'll do, we're going to move into looking at our agenda for today. So again, we have a packed agenda. So just buckle in, get your notebooks out and your pens. But at the same time, we want you to listen intently to everything that we're saying. And we'll certainly be around we'll have question and A here, but just even throughout, after you hear something, here, you'll also be able to see the slides afterwards. So please feel free just to be intentional and being able to listen so you don't feel like you have to frantically write notes down. But we definitely will be sharing some valuable information about the new guidance and just our other work that is supporting Title V. We will walk through an in-depth discussion about what's proposed in the revisions that are proposed in the guidance, and then also how we came, to those particular changes. We'll also have that high level of the blueprint, like Jeff talked about, but we'll also talk about the role of research and how new measurement can help you really measure the impact that you're making with your Title V block grant. And then finally, we'll go through kind of setting the foundation for the partnership meeting that would be coming up in the fall. This is a picture of our wonderful team. So all of our team that is here, so you see those on the stage, but we also have some of our project officers that are here as well as EJ with TVIS. So could you all stand so everybody can see you, and Ellen, our branch chief. Wait, Jenny, I think I saw you. Okay, yep. And Lewissa's in the back. So we were fortunate to bring a number of folks with us. So as you see those folks in the room, feel free to ask them, questions. Definitely, if they're your project officer, give them all the hugs. I know you've been seeing them on the screen for about 3 years now as well. But just wanted to highlight here that although we all could not be here, again, we are certainly bringing greetings from everyone from our division. And again, please reach out to them. We're always going to be here to support you. And before I turn it over to Chris to start talking and walking through our guidance discussion, are there any questions for Laura, Jeff, or I, or anything kind of burning right now and this morning before we get started? Because we're happy to address those before we get started. No, too early? Okay. All right. Okay, well, again, if you do have, again, Chris is gonna go ahead and get started, but if you do have any questions, please feel free to raise your hand if it's burning inside of you, but if not, write that down, and when we get to the Q&A, we'll answer that for you. Chris?
Do you know that feeling when you watch the clock and you say, I have a few more minutes to get my head together? No questions, huh? So I'm representing all of you. I'm representing all the feds, our partners, the experts, in talking about a couple of things this morning. We're first going to talk a bit about the application and annual report, and then we're going to talk a lot about the revisions to the guidance that got posted that you can get a copy of as of Friday. I will be doing this presentation with my colleagues, our health scientists, Karian Uesugi and Ashley Harai, who are not unfamiliar to you. So what are we going to talk about today? First of all, we'll do a quick conversation about this summer's application and report. Then we'll jump into the guidance. We're going to just review a bit, something that started a year ago, talking about the plan of how to go about the revision, talk about the background to that. And we introduced and talked about that a bit at last year's virtual AMCHP meeting. Talk a bit about the listening sessions that took place through the summer, and then look at the revisions to the guidance, which are focusing on a number of areas. There's some structural changes in terms of the content size, change in reporting approach, incorporating a bigger presence for equity as well as the blueprint, as Jeff talked about. New reporting form on assessing the Title V workforce, which is something we'll get into a little bit more. And then I'll turn it over to Carrie Ann and Ashley to talk about the performance measure framework and changes within the framework as well as the measures. So first of all, this year's application annual report, fiscal year 2024 application, fiscal year 2022 annual report. We've kicked off the season as usual, the opening up of the application on April 1st. EJ's been bothering everyone about to go in and start their applications. So he's always feverishly looking behind the scenes to see how many have started, how many don't. Do we need to reach out and get everyone in the system? But it's open now, and it will be open until the end of July, and for the July 31st due date. As you've noticed, just as we pushed out the due date on the application annual report because of COVID over the years, it's slowly creeping back to July 15th. So right now, just as a warning, you got next year, you know what you might be seeing? July 15th. But that said, is that throughout the summer, EJ is conducting learning labs to talk through any issues you have. And as he so eloquently puts it, if you're struggling with something as you work in the system and you prepare your application and your report this season, don't struggle. Give him a call, reach out to him and the team to answer any questions. There's no need to struggle throughout that. Once those applications come in at the end of July, work will begin to prepare those applications and your reports for the reviewers to take a look at. And the reviews this year are actually going to be a combination of in-state and virtual reviews. A number of you have already set up dates in September for in-state reviews. So any in-state reviews, and there'll be about 10 of them, will be happening. We're putting our toe back in the water, going to the in-state reviews and doing that in September. The rest will be virtual and going through the rest of the year until the beginning of December, just like we've been doing the past couple of years. So I just want to ask a quick question before we jump into the guidance. How many people like virtual reviews? Kind of, sort of, do you like it? How many people don't like them? Oh gosh, this doesn't help at all. I mean, it's like a 50-50 split. It's just really interesting. I think what we just saw here is what we've ourselves struggled with. There's a cost efficiency, but yet there's not the personal touch. There's not the ability to have that conversation or brainstorm and think and on the side that's not in the review itself. So we're going to continue to to work through this. It's going to be unlikely that we'll ever go back to all 59 being in person every year. But that said, we're going to see where this goes. But your partnership on this is going to be key. Okay. So now we get into the guidance. Just as a part of background, over a year ago, a number of internal steering work groups and sub-work groups were formed at the Bureau to look at areas of the guidance to see if there's ways to really improve it. And of course, we do that every 3 years. You know, because OMB process demands that we do this every 3 years, we try to take a good look. But this one was particularly important to do to reflect on needed changes. And I say that for 2 reasons. One, it's at a time in that 3-year approval cycle that sits, if approved, right before all the needs assessment work starts for 2025. In other words, we'll be about 18 months out from that next, which is traditionally about the time frame you all are starting to work and think through what the needs assessment. So if there's going to be a change and something to look at for choices of measures, for choices of work going into the 2025 needs assessment, this was a good time to do it. The second thing that it was allowed for, and Ashley's going to get into this a bit, is the performance measure framework and the measures themselves from 2015 have been collecting data, and you've been working and reflecting on the strategies you put in place to impact those performance measures and ultimately the outcome measures. That whole modeling has enough longitudinal data to start seeing if we're making a difference. Are we making a difference across time? And that allows us to say, are the measures doing what they should do in a really practical way? You know, you kind of wait until you got enough data to be able to make any kind of thought or decision about changing things. And this is a time that allowed for some of that thinking. So those 2 things come together that kind of make this guidance a really prime opportunity for looking at a better reflection of work. Similarly, we wanted to hear from everyone while we looked at the guidance, of course, and we engaged stakeholders in Title V programs throughout the summer and into the fall. So there was an analysis of the data, what the guidance looked like, and then that all informed a crafting of what is the revised guidance that took place. Now, time-wise, what did that look like? Those work groups continue to exist and will be reacting to the input from the 60-day comment periods. And the analysis of the data took place for most last year, our listening sessions through the summer and into the fall. And now we have the revised public comment is going out. We had thought April, but now it was May 5th it got posted. So one of the things that was interesting in the listening sessions that were conducted is we really didn't know how to do this virtually since we weren't getting together. Our traditional methods had been to take ideas and hold town halls at meetings and conferences that were taking place. So there was a lot of virtual meetings. You know, the performance measure work group led by Dr. Uesugi and Dr. Kogan met with states and the regions and asking about the framework and the measures. Similarly, we met with with the help from our colleagues at Alterum, we had a couple really fine virtual listening sessions that actually in some ways were better than what we traditionally had done. Oftentimes we just had a small cohort feeding in ideas, but those sessions done on Padlet, and if you were part of that last fall, oh my gosh, it was like a scream session in a sense that was really exciting because people could kind of talk over each other, you know, like, I like this idea, post this, post that, post this, post that, post this, post that, post that. And it was like, you know, you couldn't keep up with it. So there was a report that came out of that with a boatload of more detailed. Some of them were very granular, change this one little form on this one little thing. Others were expansive, you know, about we need a commitment on equity that just transcends everything. And then we also had things that were not for the guidance, but it was an opportunity for everyone to yell about what they wanted. I need technical assistance in this. I need that. I want to do this. I want to call you. I'll meet you in the corner. I mean, there was a lot of stuff that came out of that. There's Padlet sessions, and we ran with it because it gave us ideas and things that sometimes we couldn't capture that much. So a report was prepared. It was used as a basis to synthesize the conversations. So I'm going to just talk a bit about some of the things that came out of that. Now, I know all of you were writing in those pages. So if your thing's not in here, that's not means it wasn't reflected on or was being ignored. It's just these were some of the big chunks that came out that started framing and influencing where we went with the guidance. Big, that burden reduction session. Woo, boy, people had opinions about what to get rid of, what not to have, what to reduce burden, use language that we can use with partners, report only what's necessary annually. Please, why in the world is it so big? It gets this. I don't have enough character limits, It was all over the place, but we heard you loud and clear. There was a lot of stuff that needed to be looked at. If we remember, the guidance kept, it's like that house. Dr. Warren uses this thing, that rambler, you keep adding a room, you keep adding a room, you keep adding a room, and suddenly you got this house that doesn't make sense to get around. It's the same thing with the guidance. We've added and adjusted and stuff. So it was time to take a look and say, hey, can we make a better house or redesign it better? Second, same thing about the performance measures. We should have more measures to reflect program work of Title V. Equity was a huge component of that as to ways to measure that and explore that. Mental health, birth control, access, leadership. These were major areas that said these are areas we want to look and address. Children's special healthcare needs, again, tied better focus on population, public health rather than clinical and healthcare metrics. One of the things on equity, dealing with diverse Title V staff, broadening family and community engagement, making sure their voice is heard, individual lived experience, talk about clarifying expectations of our programming around going upstream with social determinants of health. These were just major areas and buckets that started framing. Now, a lot of other things, some of the specific comments about, that form, get rid of this, actually was great because I was like, oh, I never thought about that. Well, let's get rid of that if that's the case. But that said, let's break some of these things down into how they started influencing changes to the guidance. So, change in reporting approach, reducing burden by streamlining, reducing duplication and pre-populating data. Again, where is equity in the conversation of the guidance and also the implementation of the blueprint? How about workforce? Especially after COVID, programs have been bleeding, public health has been suffering. How do we find out where we're at and where we need to go with building and strengthening our workforce at the state level that can inform how the training programs are built? And then, of course, revising the performance measures and the performance measure framework. Is it needed? Not so much measurement, but is it needed to be reformed? Is there something that needs to be changed? Do we do some quality improvement? So I'm going to talk about the reducing burden. So there were principles that were at play based on what you shared at that time. Collect all information required by the Title V statute. We have to collect things that are in the statute, regardless if anyone likes them or not. Can I say, what is it, Form 7 or Form 6? Form 6, I'm sorry. Yeah, Form 6. Important, but it's really a bear to report on because it's coming from different data sources when you put it in. Eliminate duplication, respond to your feedback, streamline updating narrative sections by allowing optional narrative updates in interim years. In other words, not everything has to be done every year unless you want to change something. And clarify instructions as needed. So those were the guiding principles for reducing burden. Recommendations came out. The guidance itself is to focus only on the instructions and reporting forms, and any additional information is going to be a technical assistance resource document. This is something we're doing. You will see one volume to the guidance. There's not two parts like it is now. Because one of the things we noticed when we reflected on the appendices, which is that number, and it's very helpful, is it's didactic, it's instructions, it's examples, it's telling you about something rather than saying you have to do this to report or apply. So we've decoupled the two and only including just the guidance and instructions. The rest will be a technical assistance resource document. And what an advantage to that is that if a guidance is approved, we can't change it for 3 years. We're stuck with what goes into that thing that we all must honor. The technical assistance resource document can mature, change, be adjusted, and that itself allows us a lot of flexibility in ways to do more creative TA as well as more better instructions. So you will receive one document if you could request the guidance. And so don't be surprised and think, where's the second one? Because there is no second one. So tell your teams that if they take a look at it. Okay, so the recommendations: eliminate duplication, streamline intramural reporting, annual reporting for sections necessary with the most current information is what we're going to lean into. What needs to be updated every year? What only needs to be updated? However, when we go to do the print version, we're going to print everything out. So you have context to what those changes are. So if you leave a section alone and don't update it, state overview, your state borders didn't change, you didn't have a disaster where half your population disappeared or something like that, you can say, you know, that can stand for as it is. But then you get to a certain section that, you know, is like, what did you do this year with women? That needs to be updated. So but we want to retain all of that for context. So if someone doesn't, you know, suddenly Oregon is part of Idaho and that needs to be told to a reviewer, they understand that there was a border change, you know, okay. That said, there's updates to the forms and instructions. Sorry, Idaho and Oregon, I didn't mean to create a problem. So duplication is eliminated. Consolidation of certain sections have all come out. I know people complained, there's listening sessions about workforce is here, workforce is there, workforce is everywhere. Well, yes, it is everywhere. But why does it have to be that way in the annual report? One of the things happens, those things have all gotten streamlined into one section. And where that section sits is underneath the concept of the needs assessment. Because what the old guidance would do, or the current guidance, is you'd have, what's all these capacity sections in the needs assessment? And then we'd ask you the same thing, saying, what's it in your program today? So what we do is we've just collapsed it all under needs assessment. So any changes to those areas of capacity, partnership, you know, data, you know, can be done in the context of ongoing needs assessment in one place. And again, at will. You streamline the overview of the state so that you talk about the healthcare delivery system, the Title V program purpose and design, the emergency planning and preparation. So we get the idea of the state, the organization, and Title V all in one place. You can update it. So it's not like it's over here, it's over there, and it's over there. Sorry about that. And we consolidated the partnership sections so that you can talk about them collectively in one place. So this is the idea. We streamline intramural reporting. We're going to pre-populate sections of the narrative that are already there with the idea of optional updates in interim years. In other words, you do not need to change some of these sections if it still stands. You just leave it alone. And, you know, the print version will be a date stamp on each section. So we know when it was, the year it was prepared, but it will also then be coherent when you print out the whole print version. So certain areas, for instance, pre-populated that could stand, you update the overview of the state, the executive summary, capacity partnerships, family partnerships. You know, if there hasn't been major changes in that, you could leave it. And at will, you can change it. It's up to you. However, in the year of the needs assessment, of course, everything has to be fresh. So what are some of the things that we're going to maintaining and reporting for. We want to hear your success story each year that's fresh and new. Needs assessment update, what's happened naturally in that year would be maintained. Title V Medicaid partnership, this is an area of improvement that we want to continue to see. That's going to be there. SSDI narrative, why would that be in the data capacity section? Something you have to update because of the integration of SSDI reporting into the block. The block will be the place where SSDI reporting is going to start taking place. Naturally, the financials are different from year to year. We're going to want to do that, and that's also required in the legislation. Population domain, annual report and application information. By each of the population domains needs to be fresh each year. Now, everyone's going to ask, and they do this all the time, why do we have to do the application section, the annual report, when they're often the same? That is a requirement in the legislation. It says you have to have the plan and you have to have what's happened. So we have to do that. But again, that was one area that we did really think about creative ways to see if we could do something different. Public input, technical assistance are unique each year. So this is the required sections when you read the guidance. The rest are going to be optional and interim year reporting. Okay, so forms, we updated some and clarified instructions on some of the forms. Form 7 is now a workforce development form. It's very high level. How many FTEs do you have in Title V? How many are not? Don't you have? What's your EPI capacity? And it's a very high level form. And then there's a narrative section that's a companion as part of the needs assessment. Form 12 has been modified to capture products and pubs. So many of you provide attachments on some publications you've done. This will just capture rather than having to attach things. Just tell us if you want to. This is a really important part of SSDI in terms of building, but it's an optional section. You don't have to put anything in it if you don't want. It will be really strongly encouraged with regard to SSDI materials that have been developed. And of course, the submission on the 5-year needs assessment and optional and interim years will be this Form 7 and Form 9, which is the priority needs page. So we're trying to take off the burden of having to update everything every year. Okay, a couple big things. Health equity. From the last needs assessment and when we've really looked at it, health equity emerged as this huge voice across the country. More than half the states had health equity as part of measurement as to what they want to do or frame their needs assessment around health equity. And of course, the recommendations are how do we address this and build this and go upstream with regard to health equity and eliminating inequities. We want to highlight MCHB as a leader and partner in health equity at the center of the 10 essential health services. So what's happened? This guidance is proposing of a fourth guiding principle. We have the principle of Title V as a public health system that's engaged with families, that's accountable through measurement, and then is delivering services that are equitable. We've worked with frameworks to use language that allows for principles of fairness, socially determined circumstances within it, and it's peppered throughout the guidance to say, tell us what are you doing in terms of equity efforts. And again, it's your decision as to how and you're reporting this for where you are in your state. But look at the guiding principles. There's a big statement there about equity. The other thing too is that we've updated the graphic, which was the pyramid and the essential services. It's the now equities at the center, and it's the essential services around health equity. And we've asked in specific areas and drawn out saying, please tell us about, share what you're doing around equity. Same thing with the blueprint for children with special healthcare needs. Recommendations is integrating it throughout in the planning and reporting, make sure it's addressed in the children's special healthcare and youth with special healthcare needs population domain, and centering the voice of all families and communities throughout relevant sections of the block grant guidance as a reflection to make sure the community voice is there and the voice of families. Again, like equity, It's been peppered throughout to remind you that this would be a good place to describe the implementation of the blueprint. So with that, I am going to now stop on those three big buckets and give the last bucket, a performance measure framework, to Gary Ann and Ashley to talk the next parts. So anyway, get a copy of the guidance. That's what I'm going to say. Ashley.
Hi, everyone. It's great to see you and be in person. And I see so many friendly faces. I felt like I should stand up for how many years. It's probably been about 10 for me. And we have such a great team, like Jeff said, working together. I sit in the Office of Epidemiology and Research under Dr. Michael Kogan, and we just love supporting programs and Title V especially. So I'm going to provide a little bit of the history of the program and performance measures for Title V, and Carrie Ann will then fill in the current guidance that's right out there, or the proposed guidance in the FRN. And I think that's kind of fitting because I'm kind of the past, I guess, with Title V and working on the 2015 transformation, and Carrie Ann is really the present and future, and being your dedicated health scientist right in the Division of State and Community Health. So just a little bit in terms of looking back and looking forward, Chris kind of reminded me that that's what you do every year for the Block Grant. You do an application and an annual report. So just to kind of look at the history a little bit, we actually for the first time had performance measures back in 1997. And that was as a result of a Government Performance and Results Act in 1993. And so that as our first round, it really was an emphasis on accountability for government programs. We had a lot of measures. There were 18 NPMs, and they were all universal. You had to report on all of them. We had fewer NOMs, but a lot of different measures: health systems capacity indicators, health status indicators, state performance and outcome measures. In the transformation, we really tried to streamline this a bit and emphasized more flexibility and reduce burden. So there were no universal NPMs, and you selected, initially it was 8, and in 2018 we walked that back a little bit to 5 with your ESMs before you were submitting your activities. So it kind of aligned a little bit, but having a little bit more emphasis on these evidence-based informed strategy measures. We had a lot more NOMs then, and eventually unlimited state performance and outcome measures to meet your priorities. So that's a little foreshadowing of what the future might look like, and Carrie Ann will fill in some of that. I went back to the old guidance too and found there was a performance measurement framework. I didn't even remember this. But you can see it's pretty complicated. And there's a lot of different measures. Not all of the performance measures are even listed here, so that it might have been a little bit of a tacit acknowledgement that states have different priorities and might have been working on not all of the 18. And there were only those 6 outcome measures that were all mortality. So in the 2015 transformation, you can see it is a lot more streamlined. You know this by heart, but it really does follow the evaluation logic model. So your activities and strategies are quantified in those evidence-based informed strategy measures that influence those short and medium-term performance measures that we think Title V can impact: the access, quality, behaviors, that then feed into our North Star ultimate outcome measures of health and wellness and morbidity and mortality. And so we tried to do a little bit of a formal outcome evaluation for the transformation to help inform this next iteration of the guidance. And so we looked overall at our national progress toward NPM improvement from 2015 to 2020. And then we looked at the state level to see if those states that selected a performance measure for all 5 years had greater progress than those that did not. And that would hopefully tie a little bit more of the Title V portion to that national improvement. So we compared 2015 to 2020 for 14 of the national performance measures. There is one risk appropriate perinatal care that we did not have standardized measures data available for, but that is something Carrie Ann will mention, that we are working on getting that pre-populated, hopefully from hospital discharge data. And then we looked at the state level. It's called difference in differences analysis. So we looked at the difference, the change over time for states that did select a measure for all 5 years compared to those states that did not, their change. So that's the difference in difference. This just shows the popularity of these different measures. And you can see at the top was breastfeeding, well woman visit, medical home. We had the most states and jurisdictions selecting those. And at the bottom was a low risk cesarean, adequate insurance, and bullying. And in blue is those states that selected for all 5 years, and in red, just 1 to 4 of those years. So here is the national progress and picture, and I think it's pretty positive. There's more green than other colors on this, but it shows the kind of trend lines from 2015 to 2020. So we did have significant improvement for 6 measures: breastfeeding, safe sleep, developmental screening, injury hospitalization, transition to adult health care, and smoking. But we did see some worsening for 5 measures, although most of those were very small differences, less than 5%, and most were affected by the decline in preventive services that we saw with the pandemic, and hopefully those will pick back up again. So the 3 measures that we didn't see any significant change was for low risk cesarean, bullying, which here I used the YRBSS, which is self-report from adolescents. We did see in our national survey of children's health data that did decline with the pandemic. There wasn't a lot, in person, the bullying. We were seeing a decrease. We'll see if that happens with the self-report in YRBSS that was just released. And then a medical home. There was no change for children with special health care needs. I also wanted to note that for breastfeeding, Carrie Ann will pick up on this again, but we had been using the National Immunization Survey, which isn't very friendly for state analysis. You don't get any stratified data to look at differences by demographic factors and inequities. And so we are moving towards populating that from vital records for initiation. So that's on the birth certificate. And then for continuation, using our national survey data, actually. So we were able to work on validating and improving that data. And we do see that both of those measures did increase when using those new data sources. In terms of at the state level, comparing those states that did select the measure for all 5 years versus those that didn't, we really didn't see any significant differences there, unfortunately. So our conclusions, just to summarize, we did have that national progress for 6 NPMs, and 4 of those were selected by the majority of states. But there was no change or worsening for the remaining measures. So kind of critical review of those measures that did not have progress or were not commonly selected can inform those future changes to the performance measures. The lack of difference at the state level, we think there could be a variety of reasons. One, states may be working on NPMs without formally selecting it. I think that actually does happen quite a lot. And states may select measures because of prior adverse trending in addressing it, and we wouldn't see that. We would, that's kind of a violation of the difference in difference analysis. And then states may not be implementing some of the evidence-based or informed strategies, or none may exist. And so I know we're trying to bolster that and provide more options for successful strategies. And AMCHP is our partner in that, in the Innovation Station, and certainly John Richards at the Evidence Center. And now I will hand it over to Carrie Ann to pick up. And again, this was really the outcome evaluation portion, but we've had so much qualitative data from you all with the listening sessions, and that will tie nicely to Carrie Ann picking up from here. Thank you.
I just want to say thank you to Ashley. It's been a true pleasure working with you and being mentored by you. She is a true gem and a hero of the MCH community. So thank you, Ashley. Okay, stop crying. Moving forward. I'm coming back to this slide because now we get to talk about this big blank spot here at the bottom. And I'm going to try to talk as much as I can on what's on the slide, because I know it's impossible to see everything from the very back. So just briefly talking about our own performance measure work group revision process and how that worked. I know Chris talked a little bit about the overall process. In May, our work group, we were the first work group to convene because we knew we had a lot of work to do. And the first thing we did was set up those listening sessions with the states. We wanted immediately to hear your feedback on how the performance measure framework has been working for you, how the measures have been working, and get your ideas. We started with you. And then in July and August, taking those ideas that we heard, we engaged with subject matter experts around specific topic areas to glean what would be available out in the world of possible new performance measures. And then in September, we sort of reflected back some of what we had heard at those September listening sessions and got some additional feedback. And then we got down to work in September, October, and really deliberated and started to integrate the findings of those listening sessions. And then November to February, we were hard at work writing, researching, putting together new draft detail sheets, et cetera, to present to you today. So again, now I start with thanking you all for your participation in those listening sessions. They were invaluable. We learned so much. We repeated what we heard over and over and over again to ourselves and to leadership, to let them know that what we are proposing is reflective of what we heard from you. So what did we hear from you? Overall, we heard satisfaction with our simplified 3-tiered performance measure framework, and that it made sense, that you could explain it to partners. And so that was one of the first findings that we heard loud and clear. We did hear that desire for more upstream NPMs that reflect changes in Title V work and public health, moving towards social determinants of health and health equity. We also heard that you appreciated the flexibility from the transformation in choosing your NPMs, but you desired more appropriate choices for those areas in which you actually have priority needs. So particularly, we heard that there were struggles within women and maternal health and with CSHC and domains. We also heard that our NPMs were too healthcare focused, that our definition of the national outcome measure wasn't clear, because if you look at our list of national outcome measures, some of them kind of seem like NPMs, and we agree. We also heard about emerging topics and priorities that needed to be addressed, such as mental and behavioral health, nutrition, social determinants of health, as I said before. We also heard requests to not completely get rid of an NPM, and we heard that. And we also heard about states wanting more support to help develop state performance measures and ESMs, especially in states where the capacity is a little bit less and you just don't have enough manpower to really think through and put together those SPMs and ESMs. So this is an overview slide. I'm going to talk about all these proposed changes in depth moving forward. So I'm just going to run them right now. I'm splitting it up into 2 types of changes. We have measure changes. We've got a revised set of NOMs, a revised set of NPMs, and we've created a new measure set called the standardized measure set to help states select SPMs. And then secondly, I'll talk about the implementation changes of how we select and report on NPMs. The first one is that we now have 2 universal NPMs. The second one is that we've added the ability to select priority populations underneath your NPM. And third, we've added the ability to develop ESMs and link them to SPMs. But to point out the very obvious, the overall structure of the performance measure framework remains intact. We're not changing it. We still have our ESMs, our NPMs, and our NOMs. Everyone good? Okay. So first up, measure changes. We have a revised set of national outcome measures, and our changes are summarized on the left. First, we've removed measures that were not true outcome measures. They weren't measures of morbidity, mortality, health status, or quality of life. That is how we're defining our outcome measures now. So if there was a measure that didn't meet that definition, we moved it to either the standardized measure set because it acted more like a performance measure, or we've moved it to our Form 11, which is other state data. We actually figured out that thanks to Dr. Warren, he pointed this out, our injury hospitalization measure, which was an NPM, acts more as an outcome measure than a performance measure. So we are moving that as a measure of morbidity to a preventable morbidity to the national outcome measure set. We added outcome measures around mental health status for women, children, and adolescents, because that is such an emerging priority that we need to address. We've also added measures around quality of life, around child flourishing. This is really in keeping with the blueprint, and I know Jeff is going to talk more about that. This is our first attempt, given the set of measures that we have available for us today, to incorporate quality of life for children with and without special healthcare needs. We've also added a national outcome measure on adverse childhood experiences and adolescent firearm mortality, and we've added a sub-measure for women's health status. So the benefits to for these changes is that now we have a very consistent definition of a national outcome measure. No one will be confused when trying to explain it to partners. We're addressing emerging health issues, and we're enhancing the MCHB's application of the life of course approach that Laura talked about earlier this morning. We're not just having measures for children, if we can apply that to the women and mothers in our population that we're serving as well. So who can read this? Nobody, I know. When you get your own slides, you can look at this. This is the list of our national outcome measures. There's now 20. There's still some subcomponents. I've highlighted the changes. There's some reordering of all of our measures, so take notes. So don't think that NOM1 is the same NOM1 as it was before. On the next slide, I've made the changes bigger. So I'm going to point out what they are. In the list of adolescent mortality submeasures, we've added adolescent firearm mortality for children ages 15 through 19. And then, as I mentioned, we've moved our hospitalization for non-fatal injury for children and adolescents to an outcome measure. And then the general health status outcome measure that was only applied to children before, we now have it a sub-measure for women ages 14 through 44, so women of reproductive age. We've also added, because PRAMS has undergone a new revision into phase 9, they're now asking about postpartum anxiety. So we are adding that in addition to our outcome measure around postpartum depressive symptoms. And in terms of children and adolescent mental health status, we've added a new outcome measure with 2 parts. One is % of children ages 6 through 11 who have a behavioral or conduct disorder, and 17.2 is % of adolescents ages 12 through 17 who have depression or anxiety. So now we have outcome measures related to mental health status for women, children, and adolescents. I'll get back to the blue in a second, but at the bottom is where we've added % of children ages 6 months through 5 who are flourishing. And then if you're familiar at all with the national survey, they have 2 sort of indices for child flourishing. So they have the younger age group. And so the older age group is % of children with and without special health care needs, ages 6 through 17 who are flourishing. And then the last one is the % of children who have experienced 2 or more adverse childhood experiences. The one in blue is our only CSHCN outcome measure now, because it is our true north, as we were saying, for what we want for children with special health care needs in terms of a well-functioning system. So we've kept that one. The other ones I'll talk about in a second, right here, where we've removed NOMs from the NOM list. We're going to have questions after my presentation, Tim, so hold that. All right. I like how he sat up front so he could make sure I saw his hand. So for any NOMs that were not on that list, we've we've either moved them to the standardized measure set, which will be included in our FAD, early entry into prenatal care, drinking during pregnancy, flu vaccination, HPV vaccination, uninsurance, and foregone healthcare. Why did we move it to the standardized measure set? Because they're more like performance measures than they are outcome measures. We moved 3 measures to Form 11, which is the prevalence of CSHCN, autism, and ADD, ADHD. They don't act like a outcome measure or a performance measure. They're more information about the population in your state. So we moved it to Form 11, but they are be included in the FAD. Those that we retired and no longer be available in the FAD include early term birth, early elective delivery. CMS is also going to stop reporting early elective delivery as well. Newborn screening, timely follow-up was a developmental measure that we've never had FAD for, so you won't miss that. Mental health treatment, we've modified this measure and is now a new NPM. And we've taken out Tdap vaccination and meningitis vaccination. All right, the big news, revised set of NPMs. I put this slide up here for Michael Kogan because I want you all to know that during our whole work group process, we kept the criteria for what an NPM is at the forefront of our mind. And Michael mentioned this at every listening session and told you about these are the criteria that we have to consider for us to even to think about it as an NPM. It has to be modifiable by Title V activities. The states have to be able to delineate measurable activities to address it in those ESMs. We want to see disparities in the measure. We want to see research showing promotion of behaviors or practices and policies can actually improve the NPM. And we also have to have evidence that the measure is associated with at least one of our national outcome measures. So before we just put down a list of NPMs, we had to make sure that it met all these criteria. And so overall, our changes to the NPMs, we have now organized our NPMs by measured domains of action to help give us a little bit of a mechanism of change or a theoretical construct to understand what each measure is trying to do and what we're trying to do with our strategies, our evidence-based strategies. We've added measures related to social determinants of health, those upstream measures, mental health, and reproductive health. And we've moved less frequently selected measures to our standardized measure set. Nothing is gone completely. They may have just moved. So what are the benefits? This really targets those upstream as well as maintaining some downstream factors that are really associated with MCH outcomes. We put less emphasis on clinical care, and we're trying to help represent and address those emerging health issues that you saw in your needs assessment and that we talked about in the listening sessions. So with this reorganization under these measured domains of action, this was our ideal vision where within each of our 5 population domains, there would be one NPM to represent each domain of action. And our domains of actions are around, improving individual health behaviors. And those are the ones in gray. The yellow ones are improving the clinical health system. And those are the ones in yellow. And then improving the social determinants of health, and those are the ones in red. So you would see a very balanced set of performance measures for each domain. One exception is having a little bit more emphasis on clinical health systems for CSHCN. This is where we landed, and this is just a visual, and I don't intend for you to see it right now, but I did go through this exercise with our current set of NPMs, and you would see a whole bunch of yellow, which was improving the clinical health system, some gray for health behaviors, and we had one around social determinants of health. So now you see a lot more balance in these different types of NPMs that your state has the flexibility to address those health domains and those health issues in a manner that fits with the types of strategies that your state has the capacity to employ. Okay, so I'm going to go one domain by domain and actually tell you what the performance measures are. And so I know there's a lot of words and I'm going to read right off of it, but I think you guys are highly curious about what the NPMs are. So for women maternal health, our first NPM is the postpartum visit NPM, and it has 2 parts. One is the percent of women who attended a postpartum checkup within 12 weeks of giving birth. So that's postpartum visit access. And then part B is percent of women who attended a postpartum checkup and received the recommended care components, which is the quality of the postpartum visit. And those recommended care components that need to be met in order to meet the criteria for this measure are mental health screening and contraceptive care counseling. And this is within our clinical health systems domain. The second NPM is the percent of women screened for depression or anxiety following a recent live birth. This is really addressing the maternal mental health crisis that's impacting the maternal mortality crisis. This is another clinical health system measure. You can see the data sources. This is all PRAMs. And if you're familiar with the new phase 9 of PRAMs, this is where they're coming from. The third measure is our health behavior measure, which is the percent of women using a most or moderately effective contraceptive following a recent live birth. And then for our 2 social determinants of health measures that apply to this population domain, one is the percent of women with a recent live birth who experienced racial or ethnic discrimination while getting health care during pregnancy, delivery, or postpartum care. And secondly, this is a measure that can apply to multiple domains as well as the next one. It's a 2-part measure. The first part, 8.1, impacts the women maternal domain, which is a percent of women who with a recent live birth who experienced housing instability in the 12 months before. Oh, that's a typo. I got to fix that. Before a recent live birth. And you can see in the middle column that I've put the population domains. As you are familiar with, some of our measures can be selected in multiple domains, and I've tried to reflect that in the table here. So for perinatal infant health, that discrimination measure that we talked about just on the previous slide, that can be applicable to the perinatal infant health domain. And then 5, Ashley told you, I mentioned this, we have retained as a clinical health system measure because of its importance, the percent of very low birth weight infants born in a hospital with a level 3 NICU. Where we've not previously had FAD. Ashley has been working really hard with our colleagues at ARC and CDC to provide federally available data through the HCUP database. So we're still working out the kinks on that. And then for infants, we've retained breastfeeding and safe sleep. So I'm not going to read that out. I'll read safe sleep out. For breastfeeding, it's a health behavior measure. We still have initiation. We still have exclusive breastfeeding to 6 months. The change here is the data source. And Ashley already explained it all, so I can skip that part. So we're really excited that we're going to be able to provide more timely and data that can be stratified and for us to look at disparities within breastfeeding. And then for 7, we are just updating the safe sleep measure to capture the most recent AAP recommendations, which include infants room sharing with an adult. So now we have 4 subcomponents to the safe sleep. A is sleeping on their back. B is infants placed to sleep on a separate approved sleep surface. C is the percent of infants room sharing with an adult. And D is the percent of infants placed to sleep without soft objects or loose bedding. And then for the another social determinants of health measure, that same housing instability measure during and the 12 months prior to birth, because this impacts infant outcomes as well as maternal outcomes, this will be applicable in this domain as well. For child health, we have the housing measure again, but it's 8.2 that's really impacting the child health domain. And that's the percent of children ages 0 through 11 who experienced housing instability in the past year. This is a new, recent measuring of this in the National Survey of Children's Health, so we're able to bring it to you as a national performance measure. We have retained as a clinical health systems measure the developmental screening measure, and we have added from our old outcome measures the percent of children who have completed the combined 7 series vaccine series by age 24 months. We're adding this as a performance measure because it acted more as a performance measure, and we wanted to ensure that we are able to maintain childhood vaccinations, which we saw a decline in during the pandemic. And so we're really putting more emphasis on that for this through the NPMs. As a health behavior, we're retaining the physical activity measure just for the children domain only. I'll talk about the adolescent domain one later on. And for another social determinants of health measure, and to address issues around nutrition, we have added the percent of children ages 0 through 11 whose households were food sufficient in the past year. So this is a proxy for measuring food security, nutrition security. It was proposed in a very lovely manner by the Association of State Public Health Nutritionists as part of their work, working with some of you guys on the Children's Healthy Weight coin. So really grateful to them, but to put all this work together to propose that measure. And we're able to offer that through our National Survey of Children's Health. For adolescent health, we have retained as a clinical health systems measure, the percent of adolescents with a preventative medical visit. So our adolescent well visit measure. But new is to address the mental health crisis. We've added the percent of adolescents ages 12 through 17 who received needed mental health treatment or counseling. So this is similar to our old outcome measure, but it's a different age group, and and we're including more than just people who were diagnosed with a mental or behavioral health condition. I heard a whoop. Yeah. For a health behavior, we recognize that household smoking wasn't really capturing the adolescent substance use priority that many of you were using it for. So we've switched it, and now it's going to be the percent of adolescents who are currently using tobacco products, getting this from the YRBSS. And then for our social determinants of health measure, we are targeting those positive childhood experiences that have been shown to have a huge impact on adolescent mental health and well-being. We're going to have percent of adolescents ages 12 through 17 who have one or more adults outside the home who they can rely on for advice or guidance. I see a clap. This one I'm excited about. You're going to see two data sources for this one. NSCH, we know, is a little limited because it's caregiver report. And we heard from a lot of you that adolescent report's very valuable. So we are going to also provide in the FAD the state level estimate from the National Survey of Drug Use and Health, which is an adolescent reported measure on this. And just to point out, for child health and adolescent health, medical home still applies to those two domains, and bullying will still apply to the adolescent health, even though you don't see them on the table. And the reason you don't see medical home on the table is because we have transformed the medical home a little bit. It will no longer just be an overall measure. It will be the overall measure with the option to select a subcomponent that you want to focus on. So there are 5 components to that medical home measure. And we recognize that if you're looking at your data, you might be most limited in one area versus the other. So instead of having to work to only to improve the whole measure, you can have that specific focus on one of the subcomponents. So maybe you really want it, your state really wants to focus on care coordination, so you can pick that as a focus. Transition is the same. Didn't change that at all. And then for the last one, to capture social determinants of health, this is another area where we are trying to improve our measurement. But one area that we felt like we could expand, and we heard from a lot of listening sessions, like, can we pick a measure that's not in the CSHCN domain for our CSHCN work? So the idea that we've put bullying now as a social determinants of health measure, and the CSHCN is here. So you can pick that if you want to work on discrimination and bullying issues among the CSHCN population. There are huge disparities. And it's a lot of programming is already ongoing related to this. And so that's what's available for CSHCN, but you could also still pick it within the adolescent domain. So that was the NPMs. Now we're moving on to what is this new standardized measure set beyond more work for us to provide more FAD. This is so the changes that we've selected, we have an option for you to select a standardized measure as an SPM with existing detail sheet. You don't have to create a detail sheet, and the data will be pre-populated and part of the FAD. You can still create your own SPM as you've been able to now, but if there's a measure on the standardized measure set and you say, yep, that's one of our state priorities, we want to make that an SPM, you can click it, You don't have to fill out a detail sheet. You don't have to put in data. It's all there. So right now, this consists of former NOMs and NPMs. So hopefully this will reduce your burden as well as creating more flexibility by giving you more options to create SPMs that align with your state priority needs. It also allows states to continue working on previous measures as needed. So we didn't get rid of them. If this is still a priority and you still have a lot of programming around a particular measure, we didn't get rid of it. You can still select it. Your detail sheet's there. It's still important to us. It's still important to you. And you can keep it as an SPM. So here's the list of what is in the new standardized measure set. It's the former NOMs, like early entry into prenatal care. We've revised the drinking during pregnancy. Ashley and I were able to work with CDC to get a new revised question in the PRAMS core set. So now the measure, we're very excited about this. It's going to capture in the core questionnaire, one, any drinking during pregnancy and any binge drinking during pregnancy. So it's going to ask about each trimester, not just that last 3 months. So I'm excited about that. We put the HPV vaccination there, the flu vaccination, foregone care, and uninsurance, because again, they all acted more like performance measures than outcome measures. And then for former NPMs, as Ashley said, after our evaluation, we really looked hard at the ones that you guys told us were problematic from the listening sessions, or that weren't being well selected, or that we've not made much progress on, or that there's not a lot of evidence-based strategies available for them. So we have well woman visit, low risk cesarean, adolescent physical activity, preventative dental visit during pregnancy, smoking during pregnancy, and then preventative dental visit for children, smoking in the home, and adequate insurance. There is one new one that doesn't fit the former NOM or former NPM mold. And it is again to help us keep our eyes on childhood vaccinations. It's percent of children in kindergarten who have received at least 2 doses of the MMR vaccine. I've actually seen some of you guys have that as an SPM. So now it's going to be available as a standardized measure. Okay, I'm going to take a sec. Can I have a sip of water? Those are all the measure changes. And I'm probably way over time. Now we're going to do implementation changes. How are we going to use these NPMs? And we do have universal national performance measures in this guidance. There will be required reporting of 2 NPMs for all 59 states and jurisdiction. And the purpose of this is, based on our evaluation, really wanting to accelerate progress on priority areas at the national level. So our selection is based, going back to our Title V legislation. Our purpose is to provide and assure mothers and children, and particularly those with low income or limited availability of health services, have access to quality maternal and child health services. So we have this focus on access and quality of primary and preventative care. So therefore, we've selected out of our revised measure set, the postpartum visit to include both the access and quality portion as the first universal measure. And this is selected to really help drive progress and address the maternal health crisis that is not only a state priority, a HRSA priority, it's also a federal priority. So we really want to use this to help drive improvement around maternal mortality. The second universal national performance measure is going to be medical home. And this is intended to drive improvement in the system of care for all children. So you will have to report on medical home within the 3 domains that it applies to: CSHCN, child, and adolescents, because we want to drive improvement in the overall system of care for all children. And so how does this look in terms of our requirements? We're still going to have states have to report a minimum of 5 unique NPMs. That includes the 2 universal NPMs, and make sure that there's at least 1 NPM in each population domain. See, that was simple. The second implementation change is the ability to select a priority population. And what does that mean? I'm going to get a little technical and make you guys visualize TBIS. So when you select an NPM and set national annual objectives, we have all that stratified data. in the FAD. It's actually in TVIS, already in there, but we don't give you a way to select it, use it, or however, it's just there for you to look at and put it in your narrative as you see fit. What we're going to do is when you are in Form 10 and you're selecting your NPMs, you will have the option to select a priority population. You can pick a stratifier, whether it's race, ethnicity, urban, rural, geography, income, health insurance status, and then pick the priority subgroup within that stratifier for which ones you want to focus on. And what does that mean? So say, for instance, you pick breastfeeding, and then within the stratifiers, you want to pick race, ethnicity, and you want to focus on Black breastfeeding rates for that performance measure. You can then set annual objectives or targets for improving the rates of breastfeeding among Black infants. And that data will be populated every single year. So you don't have to input your indicator data for it. A lot of you guys were doing this already with state performance measures, and we just kind of stole the idea. But we're making it so that it's already in there. It's using the data that's available in the database. And so everything can be pre-populated. We hope that this will support your capacity to address health equity. You won't be having to create your own state performance measures, or you can still do that. But this will also be helpful during your reviews to really spotlight and highlight the efforts you're trying to make to reach equity by improving the health and performance measures for specific priority populations. So beyond that, I just want to point out and remind everybody that all stratified data for the NPMs and NOMs will still be available for state use in any other way. It's still going to be within TVIS, and it's still going to be in our all FAD spreadsheet in the FAD resource document. And now it's actually found in our TVIS public web reports. You can see that as well. And then our last change for implementation is the ability, and this, I'm looking for Julie. Hi. You can now create ESMs for your SPMs. We've heard this for years, and now we're going to be able to let you use the framework to its full capacity. If you create a state performance measure, either on your own or with the standardized measure set, you can create an ESM and link it to that. So no longer do you have to create an ESM under the NPM, but it doesn't really align to the NPM, and then the reviewers are confused, et cetera. So hopefully this is helpful. It should increase your flexibility to utilize the 3-tiered performance measure framework. So coming back to this slide, we filled in what the changes are. We hope this is a more balanced approach. We have more choice. There's now 19 performance measures, whereas before we only had 15. And we've got 2 universal measures. So hopefully that we can all collectively work on these national issues and see progress in an accelerated manner, as Dr. Bourne would say. So I hope you're excited and you see that we've tried to balance the positives from our previous frameworks for this new revision coming in 2025. So I know this was information overload, and you probably couldn't see every single word on the slides. The details, as Chris alluded to, can be found available on the TVIS resources page. We have under our guidance and documents currently the technical assistance resources draft. And now that the FRN is live and you can request the guidance will link you to this, but you can also find it yourself on our resources page. This is our old appendices. It's got Appendix B and C, and it has all the implementation changes for the performance measure framework, and it has all the new detail sheets for the new performance measures, as well as the standardized measures. And I want to acknowledge all the people who worked on this. We've done a lot of work in the past year, so it's very exciting to be here. Acknowledging Michael Kogan, my co-lead on the work group. His mentorship has been invaluable as well for leading this type of endeavor. Ashley Harai, Deepa Joshi, Krishana Lee, Jesse Lickstein, EJ Tom, and Catherine Bladitio were all members of our performance measure work group, either from DISH or the Office of Epidemiology and Research. But we also had lots of MCHB staff weigh in, and I presented this to a lot of people many times and got their feedback, including Dr. Warren and Laura and Ellen, DISH leadership, and Shirley, Jeff. I was in deep with Jeff and Sarah Beth and Dishen. As well as colleagues in DCAF, et cetera. And then we also wanted to acknowledge our federal partners and subject matter experts. Everybody at CDC who we could talk to about these measures and who collects these measures, we consulted and they were helpful. We went to the NIH Institute for Mental Health and talked to them. We talked to USDA about food security. We talked to HUD about housing. We talked to everyone we could, including some external experts too as well. So it's been a great process and I hope to hear from you guys and hear what you think about it. And that's the end of my portion. I'll give it back to Chris.
Thank you, Carrie Ann. Only 4 minutes off. That is great. Okay. I just love it. So you want to hear a secret? So those detail sheets on the new measures have been sitting up for 3 or 4 weeks on that website. And we were all taking bets at what Epi was going to find them and start like, what are these? These aren't it. And we were like, eh. Had to do with deployment of when we could deploy things versus when the FRN came out. Haha, no one found them. Anyway, that said, we do just want to wrap this up and take any questions you have. I know you've been sitting for a really long time. Just so that you know, the next part of this process is you got the 60-day notice now and it ends July 5th. So by all means, get a copy of the guidance, comment, send things in, and that they will inform the revision to the 30-day. In July, August timeframe, we will be sending it out for the 30-day to OMB. You could still comment at that point, but hopefully that will be what will be the final version. Fingers crossed, within 90 days, OMB will approve it. And the idea is we'll do it and have it, and there'll be a framing for the partnership meeting in the fall. We'll get into now, once it's real, we'll start doing the technical assistance to make this happen for you. But we really do hope that this reflects a lot of what you've shared and what you said was important and what needed to be changed, because this is at the heart of federal-state partnership. So with that, who wants to stand up first to stretch their legs, or let's have some questions? And I'd say Carrie and Ashley, get ready. And Ellen, you've got a microphone to share.
Why are the data? Some states are both doing it, and in Kansas recently, Kansas Department of Education decided not to do that because parents didn't want the children to do that. Students actually, high school. So I think there is a talking between Kansas Department of Health and Environment and Education Department are talking to transition to PhD, but I'm not so sure 100% where it is. So that would impact the measure.
Thanks for pointing that out. I appreciate that. We actually are relying less a little bit on YRBSS, I think, with this new guidance. Just have that one performance measure on smoking, around tobacco use. But thanks for pointing that out. It'll probably end up more like Koreans. Already, there weren't 100% of states participating in YRBSS anyway, so we knew that. It's been that way for a while.
Good morning, everyone. The presentation has been wonderful, and I was hoping that we could get the PowerPoint slides because it's not on the app. So is that possible?
Yeah, we'll be getting those PowerPoint slides out to everyone after.
Good morning, everyone. I'm so excited to be here, but definitely, first, I'm an official photographer, so I would love to get pictures for Mr. Michael Warren, because I see all these amazing panelists that we have here today, and all his keywords upstream, looking back, looking forward, and then the performance measures are just amazing. Adding the social determinants of health, also looking at some environmental things and some of these disasters that we're dealing with. And today, y'all got into a little water here, but we're okay. But some of those things do affect maternal and child health. So thank you. And so please don't leave because I have to get a picture for them. Okay?
Nuri, once you get the mic.
And stuff. Hi, good morning. Thanks so much. My question is super nitty gritty. I'm looking on the Federal Register site and I see the block grant guidance posted for comment, and I see another thing posted for comment that looks like it's the performance measure. Are those two separate things that we request separately?
There should be only one thing there,
Okay.
Narit, so I'm not quite sure what that is.
The second one is called also public comment request and MCHP performance measures for discretionary grant information. Is that separate?
No, that's separate. Yeah, you want to do that?
Different measure.
Yeah, yeah.
Thank you.
Narit, I expect comments.
You'll get them.
I know. I think one of the things up here, Tim, but what I will just say is one of the things that is so impressive about the performance measure framework is there's so much more flexibility. And also as a partner, we're giving a lot more fat so that you can create things that exist without helping reduce burden, hopefully. Yep.
My name's Tim from Alabama.
Okay.
Hi, everyone.
See you.
I'm looking at the old application on the HRSA website now. And I was curious about the SOM 17.3 and 17.4. Are they taken out?
What? NOM, what is 17.3?
SOM 17.3, percent of children ages 3 through 17 diagnosed with autism spectrum disorder. I didn't see that on the slide.
Yeah, those are the three measures along with the like 17.1 that are gonna be moved to the Form 11, which is part of the FAD. It's called our other state data. So I'll basically like prepare all the FAD for that and put it in the other state data.
Okay, cool.
Hi, Blair Lund, Montana. So as a lower capacity, less funded state, and I just want to make sure I understand correctly, we only choose one NPM per domain because of the ability to have more impact. It seems like you're taking away some flexibility with those universal performance measures that of our 5, 2 of them are now prescribed to us that we have to choose. Am I understanding that correctly or not?
Yeah, I mean, that you're seeing it as you're reading it, yeah. Okay.
Good morning, thank you for the presentation. I just had a few questions, especially the large emphasis on mental health for youth and children. I'm familiar that YRBS does ask questions regarding LGBTQ sexual orientation questions. Has there been a push from HRSA to do something similar with CRAMS? I know in Arizona we wanted to include that as part of our state added questions so we can start measuring that. But I've seen the latest report from CDC saying that queer youth experience some suicide, other mental health conditions that we integrated. I figured I would ask that. And then second, one of the struggles that we have in Arizona is NPM 6 with developmental screenings. A lot of emphasis goes on home visiting, and that measure does not capture screening done by home visitors, but by the pediatric pediatrician's office. So has there been also an interest in trying to change that a little bit, because that's where we have a lot of misalignment? And I'll just make a comment that I'm glad that we're kind of moving away from the National Immunization Survey for breastfeeding, because that was a struggle on our end as well. So we appreciate the change to the other survey.
Thank you. I will point out that for our YRBSS measures, I think we do stratify by social orientation and gender is available from YRBSS. PRAMS, we don't administer, that CDC, and so any questions related to incorporating that more into PRAMS is in their purview. And then the last question about the developmental screening, we're keeping the measure is still the same, and the National Survey of Children's Health, we haven't changed that. Thanks for pointing that out.
So let's have one last question and then we'll take a break.
Hi, so this is Nerita again from Oregon, and actually, it's not a question, it's just a thank you that I'm excited to see housing and food security. Thank you. We're working on our state performance measure, really trying to work full upstream, and I know lots of states have, so we appreciate that you heard that.
Thank you, Nuri. So this is just the beginning of this journey together. And please, the best thing to do next is to get a copy, take a look, reflect on it, and provide comment. With that, let's take a 15-minute break and we'll reassemble and finish out our morning. Carrie Ann there was something that she wanted to share about the performance measures as well that she that slipped her mind, I guess.
Yes, well, and it wasn't on the slide. One somebody's question afterwards, so thank you very much for asking this question. I should have put this up here. One thing that we neglected to put up there about the universal measures is we plan to, and to help alleviate this transition and the maybe additional burden placed on states due to the universal measures, is to prepare standardized sample ESMs for the two universal measures that states could use if it was appropriate for them to use. So we will have a set, we're going to work with John Richard, and his great team, his great mind and his team, and come up with some set standard ESMs that you might want to adopt for postpartum visit and medical home. So hopefully that will be helpful. And there was one other thing.
We'll come back to
I'll come back to it. Yeah. Okay. Thank you again.
All right. Thank you, Carrie Ann. So welcome back from the break. I hope you all had an opportunity to stretch and greet each other, connect with colleagues you haven't seen in a while. So we're going to get started with our last section for this morning's session. First, I'll just introduce myself. I don't know. Some of you I know, but not many. I haven't been here that long. I'm Erin Patton, and I work predominantly in the East with regions 1, 2, and 3, but also with AMCHP. So I do have an opportunity to get a national perspective. So for this next section, we're going to have an opportunity to hear from Dr. Brasco. He's going to talk more about the Blueprint for Change. And then we will hear from Dr. Ray Lee, who is the Director of Research in the Office of Epidemiology and Research, and she'll present on translating research into practice. And then finally, I'll come back and provide a little bit of framework and kind of preparation for our fall partnership meeting. So with that, I will turn it over to Dr. Brasco.
All right, so Erin just broke a really important rule. She called me Dr. Brasco. Most of you know, if you call me doctor, I walk out of the room. I'm going to forgive you this time. Okay, I'm Jeff. Before I go through this, how many of you have already seen me do this presentation at least once? All right, not too bad. Okay, excellent. All right. How many of you feel like you have way more money and too much resources to be able to do the work you need to do there? So one of the things that struck me about, when Ashley was presenting about how things we chose as measures didn't necessarily change in states compared to where we didn't. Remember, partly the issue is just a measure of scale, right? I mean, I think about in Florida, we had about $9 million for our SHIN population, and there are 800,000 children in that category. It's about $10 per child. And Medicaid probably spends $15 billion with a B. So the idea that we might be able to, do this is really hard. A lot of what I'm going to talk about in the blueprint is how we can do that. So be that, what was the story that we always read as kids for those of a certain age, the engine that could make it up the hill train? I sort of felt like that all the time. I hope you'll see that in that context. All right. So just to kind of level set, to remind everyone that most children in the United States are basically healthy, don't have a chronic condition. About 20% fit into the category of special healthcare needs. By the way, for this afternoon, for the SHIN directors who are coming back, we're going to spend a lot of time digging into this because it turns out to be more complicated than we thought. We need to think about whether we have to, in some sense, redo these categories. And we really want to get your input. So I hope you join us this afternoon. Within the SHIN population is the CMC, right? These are the kids who they're probably only 1 or 2% of the population, but have much greater healthcare needs and account for 40% of mortality among children. So it's a particularly important group to think about. One quick aside, and this came up on some of our calls. A lot of our advocates, a lot of our families, and many of us have felt like the word special is not appropriate. It's pejorative. And it's in legislation, so it's not easy to change, but we do have sort of a workaround. So I'm going to be using this word SHIN over and over again because it's much faster. What you hear can vary. So you might be a traditionalist and you say special healthcare needs. I think specific healthcare need probably makes the most sense because it may vary dramatically from child to child. And some of you are really in the community space. And so you might think of social health and community. So when I say SHIN, you get to decide what it is you're hearing from me. That whole idea came out really in the 80s. It came primarily from families and from several other healthcare professionals that said, you know, children with a condition have more in common with each other than children who don't have a chronic condition. So we should start thinking about them from a policy point of view as sort of one group of kids. And that was in the 80s and 90s. In 2000s, we started talking about the 6 core components. I'll show you a slide of that in a minute. And then we sort of went along the line and we felt like it's been at least 10 years or more since we thought strategically about the SHIN population and what are the things we need to do to improve outcomes. So that's sort of where the blueprint comes from. Get to in a second. But I want you to know we have not forgotten the 6 core indicators, right? They still exist. We're still keeping track of them. They still are the way that we think about a well-functioning system. And as you heard, it's still part of what we're measuring and keeping track of in Title V. So that has not gone away. And many of you, of course, will understand that we've been working for the last 10 years on these standards, both the national standards for the system of care and national standards for care coordination, extremely useful tools. So if you're thinking about, you know, how do we do care coordination? We want to know what the national standards are. They are there. If we're writing a Medicaid contract about SHIN population, we've got things to really rely on. So the blueprint for change, really, a lot of you know this came out over the last 3 or 4 years. You've all been participating in some ways. We did focus groups, we included families, we included youth, experts inside and outside of government to come together. And that was sort of the basic idea to make sure that we had a wide input. So this is not really MCHB's blueprint, this is our blueprint that rises from the field. And as I mentioned before, it came out this past summer in 6 papers in pediatrics. Have any of you read all of these one after the other, sort of back to back? Anyone besides me? Yeah, a couple of people. So when I started, Michael and Laura said, well, what's your job, Jeff? It's to implement the blueprint. If you read these back to back, it is completely and totally overwhelming. There are 12 principles, 40 recommendations, and the strategies are things like end racism. It is not easy. There's a lot in there. I will also say that each of the individual articles has its place. So I'll come back to that in a minute. There's a lot there. To make it a little bit more straightforward, we talk about how here's the big idea, right? That there's sort of 4 parts of this: quality of life, access to services, financing, and health equity. And our big goal is for children to thrive. This seems pretty straightforward. But part of you might be saying is, wait a minute, haven't we been doing this all along? Right? Isn't that what we've been talking about for 30 years now? And that's true, but the things that are really new in it are quality and equity. We heard over and over again from families that, yes, you guys have been measuring the number of immunizations and childcare visits and things like that. But what really matters to us is our children, are they able to play? Are they learning? Do they have friends? We really want you to think about quality of life, and not just for our children, but for their siblings and for us as well. So one of the big messages we heard over and over again is we need to think differently about what we're measuring, and quality of life is a key one. And the second thing we heard, and is really, and this conference is really a lot about equity, is we want to make sure that every child is getting access to the care that they need so they can grow and play, become healthy adults. To try to make this more manageable, we tried to turn it into plain language. So this is what you should be hearing from us all the time. And we hope that we'll be hearing from you soon. That as you're talking to your partners, as you're talking about folks about what is the blueprint is that every child gets the services they need so they can play, go to school, have friends, grow up, become a healthy adult. And so the grownups and siblings are thriving too. We try to make it plain language so people can kind of picture it: a child going to school, a child learning, having fun, playing. And notice that built into this are some pretty important concepts, right? So every child gets what they need. Well, an equality statement would be every child gets the same amount. An equity statement is every child gets what they need. We think this is particularly important if you're in states where talking about things in plain language is a much more effective way to communicate, and that you need to be making sure you're using the words that people can hear and not get put off by the words that you choose. And then child thriving, play, go to school, have friends, transition to adulthood, become a healthy adult. It's also useful if we want to talk about why our work is so important. So I would say that children are important in and of themselves, but with some audiences talking about the future workforce, the well-being of our population is also going to be important. And caregiver well-being is there because if you look in the Shin population, there's 13,000 different conditions, and it's hard to measure every single one of them. So caregiver well-being might be sort of the single common denominator. If a system of care is working well, then caregivers are probably going to be thriving. So how does this all fit together? So for those of you who've been around the Title V world for a while, this is a useful sort of figure or graph. For those of you not, don't worry about it. But the main idea is that we have the 6 core components, and that's kind of those gears that work together in a well-functioning system. And the inputs in some sense are the financing and the access. There's a system of care that kind of chugs along. And what comes out is quality of life and equity. And you notice the 2 wrenches at the top. So that's the care coordination standards and the system of care standards. And so we think of those as tools that you can use to make sure that things are running. Does that kind of make sense to everyone, the way these things fit together? And just kind of a couple use case ideas. So depending on what you need to do, you might choose different things. So if you're thinking about, well, how will we improve equity in our Title V program? Clearly, what's part of the guidance? Well, reading the article that was written about equity, and by the way, all of the articles have family members as authors, sometimes as lead authors. So if you read what's there about equity, it has a whole bunch of strategies, a whole bunch of recommendations that you can say, oh yeah, we're already doing this, or we could do something we're doing now a little bit better. In terms of measuring the system of care, that's where the 6 core components come in. And as I mentioned before, if you're working on a contract or some specific things, that's where the national standards are. In Florida, when we were creating our healthcare plan, we explicitly said as part of our ITN, our contracting, here are the national standards. This is what we want you to do. So you don't have to invent it yourself. Same for care coordination. All right, so now that the blueprint makes sense, how are we actually going to implement it? And Shirley mentioned this before, totally stealing this. This is not new, right? And all of you probably have heard all along, measuring what matters to families and youth. John Richards happened to be walking by my office a couple months ago, and I said, John, what do you think about this idea? We're going to, measuring what matters. And I taught him a little bit what it means. And I said, you've been using this, right? He said, using it, it's tattooed on my arm. So what are the components of this? First is, as I mentioned before, we want to measure quality of life. Yes, we need to keep measuring other process things. We want to know, are kids flourishing, right? So one of our new measures. We also talk about one condition-specific measure. That is, if it's in hemophilia, it might be joint bleeds. I'm going to show you in a minute for deaf and hard of hearing, it's language acquisition. But depending on the condition, there might be certain things that are particularly relevant. I'm going to stick for a minute on the population part, because this is really hard. Now, in some ways, you've been hearing this already. You can think of the blueprint as population health 2.0. What we're really trying to do a lot of in our division is not worry so much about the number of children we've reached and think about the percentage. So yes, you might have done these trainings and had these website hits and talked to these families, but what percent of children are reaching that quality outcome? What this does, and this is where the impact part comes in that I mentioned before, when you do that, you have to think at a systems level. You can't just think about how many children in front of me, and we'll talk about it, Eddie, in a second. And then built into that is not just what percent of children are achieving a certain outcome, but then we want you to disaggregate the data based on what's the historically relevant populations. So in some states, it's going to be rural populations. Other places, it might be limited English proficiency. Other places, race, ethnicity, maybe all of them. But if we're disaggregating the data and saying, are all populations meeting that standard? That's good old-fashioned public health. It's also equity. That is the way we can get there, by measuring it and making sure. And that's where that last piece comes in, about holding ourselves accountable. And it's not holding ourselves accountable like, well, if you didn't get to the goal, you're in big trouble. The accountability comes like, did you have a good plan? Were you looking at the data clearly? Did you follow it up and monitor it? And then when you get a result, after a year, 2 years, do we make an improvement? Do you have a way of then going back and saying, okay, this worked, we need to keep doing it, and this didn't, so we're going to change. So the accountability is for all of us to make sure we're headed in the right direction. So just give a quick example of how this might look. So I think all of you know that in the newborn hearing screening, it's the EDI program, the Early Hearing Detection Intervention Program. We identify children who are deaf and hard of hearing. So for years, we've mostly been measuring the 1-3-6, 1 month screening, 3 months diagnosis, and 6 months connected to Part C. But if we really think about what we're trying to do in this program, what's our goal? It's language acquisition. We want children to be able to, whether it's sign or spoken language, we want them to be able to communicate and use language to grow and thrive. So what we're going to start asking our EDI programs to do, we're going to think about this for all of our programs, is say we want you to report % of 3-year-olds, because that's what the legislation is, % of 3-year-olds who are deaf and hard of hearing, whose language is in the average range. So now if it's the % of children, you need to think about every single one of them. And what's the first thing that our EDI directors say? You only give us $235,000 a year. There's no way we can do this. And that is true if what you're doing as an EDI director is, and many do this because they're crazy committed, they actually get in their car and will go drive 200 miles to get a family to drive them to the appointment. And that's a wonderful commitment, but you can't do that for every child in your state. You need to work on Medicaid to say, why aren't they doing the appropriate transportation? Or you need to work with healthcare professionals to say, you get the idea. So the idea of an EDI director then is to show the pipeline. Where are we as a state? What % of our children are getting where they need to get to? And where are the leaks in the pipeline? What are the things we can be doing better? It might be, yes, we need to train audiologists better in the newborn period, but it could also be early care and education needs to improve. And that would be the best way to improve language. Maybe social determinants of health matter the most. So thinking about how you work with partners. So the idea is to move to a population level thinking and not just trying to get to every child one at a time. So last slide, because this is a transition to talk about research networks. We have a translational research network for the Shin population. We're going to talk about this more this afternoon. The questions that they're answering should be questions that are relevant to you. So we really need you to be participating in this and telling us what are the things that we need to know to be able to move forward. So yes, there are evidence-based approaches, right? So you have your ESMs, but there may be questions you still haven't answered that you need help answering. And that's part where the research network comes in. And these are some of the key ones we're asking our research network to look at right away. If we're going to say measuring what matters, well then, okay, what exactly are those quality of life measures? So hopefully fairly soon, I'm looking at Sarah Beth, maybe in a year, we hope to have a website that says, here are I think there are about 21 different measures of quality of life. And here when they might be most useful for you, and here's how they might be applied in different programs. And as mentioned about looking at quality of life for caregivers, there's a lot less of research on that, and trying to figure out the right way to do that is going to be really important, I think, for knowing whether our systems of care are working. Transition to adulthood too. We tend to measure only healthcare transition. We need to think about independent functioning, connection to community, and those kinds of things. So we're going to try to have a more robust set of measures to know whether we are being successful in these fields. And I think one of the hardest things for all of us in this room is how do we measure policy success? So Carrie Ann and I, she's not here anymore. Carrie Ann, there you are. We talk about this all the time. So if I am a Shin director in a state, and we spend a fair amount of time working with Medicaid to make sure that parents get paid as caregivers in their state, right? Or as family navigators, as community health workers, I've done something huge. At a population level, I've reached everyone in my state. But then how do we measure that? Do you get credit for every kid? How do you measure that policy change? So that's another thing we need to kind of think about. And then the last thing here is about family engagement. There are, 5,000 different definitions of family engagement. And you say it and everyone thinks you know what you're talking about, but it's all slightly different. So we're going to try to get a little bit better at defining exactly what this means, and then maybe how to make sure that we're doing it in a way that's as effective as possible. I'm going to turn it over to Ray in a second, but just one last thing is so in implementing the blueprint, you should be hearing soon that the American Academy of Pediatrics won the award to be able to help us at MCHB talk to all of you. So you should be hearing soon, because we think that you are a prime audience for making sure that the blueprint gets implemented. I'm going to come back to what I started with my earlier remarks. This is not something new. This is not a new imposition. It's a way of taking what you're already doing and trying to think about it in a way that has the greatest possible impact. Consistent with our strategic plan at MCHB, and embedded in the guidance. All right, so Ray's going to talk about some research networks, and then we're going to answer questions. Thank you.
Good morning, everyone. My name is Riley. I'm the Director of Development Research in the Office of Epidemiology and Research. It's always a mouthful. It's my great pleasure to be here today because this is my first time to be at AMCHP and it's the first time to be at this skill build session. Different from the other speakers, I'm not an old friend, but I'm a new friend. So before I joined MCHP, I was working with CDC for the Division of Reproductive Health. So I've been working with the MCH programs in the States through the CDC field assignees, as well as the partner organizations like ASHTO to work on the MCH programs. After I joined MCH in 2020, I volunteered to be the SME for the state block grant reviews for example, for the state of North Dakota and also for the state of Wyoming. So as I said, I'm a friend. Yeah. So in this presentation, I will share with you our research programs as well as the ways that we can partner together. You may be asking, why am I here? What you will get from this presentation? I just want to share with you a little bit story. So you have a lot of interactions with Ashley and the Division of Epidemiology through the data support. And we are another part of the OER, and we are the research part. And traditionally, we didn't work a lot with the state programs. And then after the MCHP strategic planning, there's one called impact. So we have been thinking how we can make our research be impactful. One way to achieve impact is how we can translate the research into practice to really help our state programs, including Title V programs, to improve your practice. So I reached out to Chris, and Chris was very excited because he said that was exactly what DISH would like to do, to use research to inform practice. And we worked with Carrie Ann to develop a mapping tool to look at what are the alignment of our research in our research networks, as well as to mapping them with the state NPMs and NOMs. And after Shelley was on board, she was fully supportive of this idea. That's the reason she invited me to present. So the purpose for this, for my presentation, is really to plant the seed for the research to collaborate with the Title V programs, so we can think about ways to translate research into practice, and also you will work with us to ask the meaningful research questions. We can be helpful. So I will re-emphasize the Title V's evidence and education needs, as well as the benefits of the research practice partnership. I will share with you our current research programs relevant to Title V programs and suggest a few next steps for collaboration. So I don't need to re-emphasize. We know for Title V programs, the evidence-based and also the data-driven is a foundation. And every year, the states are required to report the NPMs, NOMs, and also DISH spend a lot of resources, as Carrie and Ashley and Chris presented. They spend so much resources to update the guidance for the reporting in order to keep up with the new evidence. How many of you have used the MCH Evidence Center that I showed here? Quite a few. So the MCH Evidence Center is a way for MCH to support the evidence for the Title V programs to identify what are the evidence-based interventions and provide tools for you to better incorporate the evidence into the practice, and also provide technical assistance. And they also want to identify evidence gap for each of the NPM and NOMs. They synthesize evidence. What are the existing evidence? What are the gaps of the evidence? I actually selected one for the wellness visit because I saw it's one of the common measures across the states. There are evidence gaps here identified. So what do we do with the evidence gap? Yes, we do more research and get more data. So how many of you have you ever worked with researchers, either from universities, academia, or from MCH and CDC? That's great. We have already had a lot of supporters for this research and the practice partnership. I just want to introduce this concept. What's the definition for the research practice partnership? This approach is intended to promote efficient and relevant interventions, given that both researchers' perspective and practitioner experience shape implementation. This partnership emphasizes research with communities, agencies, and systems, rather than research on those systems. So we work together as a way to make interventions relevant and build capacity. And a lot of federal agencies have recognized the importance of the research practice partnership. This is what I got from our sister agency, ACF. They, for their Office of Planning, Research, and Evaluation, they deliberately said the role of the R3P is actually added research, practice, and policy partnership. It's a long-term collaboration aimed at education improvement or equitable transformations through engagement with research. These partnerships are intentionally organized to connect diverse forms of expertise and shift power relations in the research endeavor to ensure that all partners have a say in the joint work. So this spoke very nicely of the research practice partnership, because as a long-term researcher, I have been doing research for almost 20 years. So my most exciting research I could remember were actually coming from the field. So when I was in DRH, we worked with the state MCH programs to use the economic evaluation to show the return investment of expanding the long-acting reversible contraception, to see how to show the return investment to the Medicaid programs. What are the savings if the Medicaid programs cover LARC? And several years ago, a few states reached out to us, CDC, because they really want to show the benefits of extending the postpartum coverage from 60 days to a year. We actually put a proposal together to use the CMS data to do the analysis. And we see today, and there are many states expanded the postpartum coverage through at least a 1 year postpartum. So next, I want to share with you our current efforts in MCHB to foster the research practice partnership with the Title V programs. And we have several exciting programs, research programs that will be relevant to you. So the first one I want to share is that we have a collaborative health equity management project, which just started 2 months ago. And for this contract, it will support the development of the MCH, the maternal and child health equity measures at both the state level and the community level. And we will also have a composite measure to measure health equity across the health equity stratifiers. So at the end of the contract, you will get a data table. You can search for your county and your state to see what is the level of the health equity in maternal and child health in my county compared with the other counties. And we also have that's the external focus. We also have internal focus to help the MCHB programs to develop health equity performance measures. And the material that Carrie and Ashley shared was very helpful for our health equity, for our CAM project. So we can think about, based on the NPM, the new NPM and NOM measures, how we can use data to demonstrate, to show the data for the health equity in those measures. And second one, we have autism transitional research project, and the focus of the ATRP is to investigate the social determinants of health and risk factors associated with healthy life outcomes among the autistic youth and adults in transitional age. So for their new funding cycle, they specifically asked to partner with the Title V programs. They want to get the Title V program support to facilitate equitable outcomes for autistic transitional children. So they are intended to reach out to you to understand how many states are focused on the autism transitions, and also to work with you to develop the transitional measurements and tools for measurements and help the knowledge dissemination. So at the beginning, I thought they would attend this conference. We would invite them to come to this session. Unfortunately, they couldn't make it, but we will continue to foster the collaboration through DISH to connect the Title V programs with ATRP. And Jeff already talked about the Shin Research Network, and Sarah Bass is there. And if you have any questions that you can collaborate with the Shin Research Network, please contact her. And we have an exciting new program coming in. It's still the receiving application. So it's a maternal health research collaborative for minority serving institutions. For this one, it's a fiscal year 23 NOFO. We received $10 million from the Congress to support a research network to support the capacity for the minority serving institutions to conduct maternal health disparity research. It has two components. One component, we will support 16 research networks for them to conduct maternal health disparity research and find the community-based solutions. We have one coordinated center that will provide the capacity to support the research network, the research centers, and the other MSIs to conduct maternal health research. So this one, the closing date is June 12th. So if you know any minority serving institutions in your state, please let them know about about this great funding opportunity. And when Shelly told me about the skill building session, she said, we always want to have some take-home message. So I want to suggest a few next steps for collaboration. So after the session today, can you identify one area you feel research can help with your work? And think about how you can help the research networks disseminate the research fundings. And think about how you will collaborate with MCHB research programs and what are the barriers and challenges and opportunities. We know it's not easy to build the research practice partnership. We really need to take the deliberate effort to think about it. And as Chris said, for the new guidance document, today's presentation is just like the beginning of a long journey. I also want to copy that. For our research partner, research practice partnership development, this is just the first step. We want to introduce the idea for you to think about it, and we will continue the conversation in the future. And at least in October, we can continue some conversations at the federal state partnership meeting. And if you have any questions, I will be here and let me know. Thank you.
Okay, so thank you, Ray and Jeff. So just to wrap us up, I'm going to talk a little bit about the partnership meeting that we're planning for the fall. We're really excited to be able to see everyone again in person, and for anyone who isn't able to be here, to see them in person. This will be the first in-person partnership meeting since 2019. For the last 2 years, we've met virtually. We've had an opportunity to discuss COVID, as that was, what was happening at the time, and how maternal child health and Title V were working in that space. We also talked about youth and family engagement, as well as we talked a little about state action plan. And then just last year, we really dove into addressing system challenges to advance equity. And there we explored internal and external approaches to systems change. So all of that really has laid the groundwork for what we're planning for this fall. We are gonna focus heavily, as I believe Chris mentioned, we're going to focus heavily on implementation of the guidance, as that will be kind of our framework for the partnership meeting. But there's going to be a really strong focus on health equity. For anyone who this is your first partnership meeting, who will be your first partnership meeting in person, like myself, it's an opportunity, another opportunity to engage with your peers and colleagues from other states, learn about what they're doing, hear from some of our TA partners that are supporting the work that you do, and really strengthen the federal-state partnership that really is what is Title V. So over the next few months, you can expect to hear from AMCHP. They're going to be reaching out to learn about what you all are doing in terms of health equity, how your work is being moved forward in your state and what your needs are, because that is what we're going to lean into for how we plan, you know, what topics we're going to discuss, what support we'll be able to provide, and what speakers we'll have there. And then finally, we are looking forward to receiving those comments about the guidance, because again, that's another space where we'll be able to get information on how we are going to inform the agenda for the partnership meeting. So there is more to come. You know, please, we'll have details about everything that will be coming out hopefully soon. But if you do have questions in the meantime, your DISH project officer is always available. You can feel free to reach out to me, but we're all here to support. We're excited about the next couple of months and what's going to happen in the fall. And so we look forward to seeing you there. So with that, are there any questions for Jeff, Ray, or for me?
Hi, I'm Allison. I just wanted to ask for your thoughts of, particularly Jeff, but others on the panel and also in the room, about the quality of life measurements for kids and families that are really approaching quality of life from an anti-ableist perspective. And a lot of quality of life measures that we have right now are focused on things like functional ability, and that is not necessarily what matters to kids and families, what they think about quality of life. So interested in hearing your thoughts about that.
Thank you, Allison. And thank you, Allison, for reminding me that much of what is in our blueprint came out of the work of Allison, Meg, Mo, and many of the others in our MCHP funded COIN, Children's Special Ed Needs, or 10 state demonstration parties. I think one of the key messages we got from that is about quality of life and activity. So a lot of what you see in the blueprint came from their work. So that's the first thing. Second thing is that you can see I rushed through things, and I want to make sure that CHIN directors and others know that this afternoon we really have to dig into some of these things. One of them is how we really measure and choose the right measures. That's one thing. Secondly, we need to talk about something like ideology. Whether the CHIN screener is identifying the right kids. We're talking about the possibility of a pretty big change. We need to get feedback from people. And the third thing is about medical home. It's now one of our universal measures. You know that, especially for children that are complexity, but the CHIN population in general, it's much harder to meet that criteria. And so we're going to dig into that. We have some funding opportunities for that to talk about in a bigger sense. So please join us this afternoon. And to answer your question, I think it's exactly right. That's part of what we're talking about working with our CHIN research network on. And you'll notice that I said playing, going to school, participating in the community. I didn't say you're able to read, you're able to walk, you're able to do specific things. And so the condition-specific measures may be that for some populations, but for others it may be different. So thinking about what quality of life means is really critical. In the transition space, for example, is another good one, where a lot of times all we hear about is someone that gained more employment. It actually might be more meaningful activity, and again, connection with the community. So that's part of what we need to think about when we talk about measures and trying to get to that next step. I don't know, I don't see Michael Kogan here, or I don't know, actually want to say anything about, but I know that for the national survey, we're starting to think about whether the measures we use for flourishing other things are need to be sort of updated for exactly the same reasons.
Yeah, I also want to add that for our ATRP, Autism Transition Research Project, they look at health life measures, not only in the health field, they are looking at other sectors, for example, the job training, the housing, as well as social security disability insurance. We're actually working with them to try to have some data linking to link the Medicaid data with other social security data, the vacation returning data, and also our social determinants of health data to be able to measure the comprehensive sectors of the healthy life, not only the health sector.
And I'd like to add one more thing about measures, because you hear us talking about it a lot. And so you saw for the EDDI program, part of here, we talk about length, of course, and average range. And for some of you saying, well, for a child who has sort of underlying conditioning, that may be too much to reach for. I want to point out that just having measures like that changes behavior. Even if you don't have a perfect measure. And the example I'll give is, you've heard from Laura before, there's a LEND grant for a long time. We used to measure our, how well we were doing as a LEND program, leadership education for neuro disabilities, by the number of trainees we had, the number of papers we published, the number of grants, the number of clinical encounters. We said that's not really getting to population level impact. So about 10 years ago, we started working with two of our neighboring communities, East Olivana and Overtown. And we looked at having sort of basically combined strategic plans. And our outcomes were kindergarten readiness and high school graduation. And we saw real improvements over time. We actually published that just recently in Maternal Child Health Journal. What's really important is not so much that we change those population level outcomes, it was to change our behavior as an institution. And we were still thinking about grants and papers and things like that. We started thinking about, will this have an impact on the population? Will we see real changes in the community where it matters? So even though it was not a perfect measure, even though it wasn't, a scientific study per se, it changed the way we're doing things. So again, even if we don't get the measure perfectly right, we agree that it aims at something that's really important, it matters to families and to youth, all of us, that changes behavior in a really positive way.
Hey, this is Taylor Stroke from the Study Participant. I'm really curious more towards training, but also thinking about research practice partnerships, something I've been wrestling with is state health departments and notoriously partner with university systems that have historically continued to impact those populations who are also experiencing disparities, Black, brown, community. I'm wondering what a journey has looked like, or best practices folks have used to widen those partnerships to move away from more of this research one-based university institution, or those who are not minority service population, to just develop a different network when they're established over time.
I have a hard time hearing the question, but I think I understand what you, I heard most of the questions. So what, I think what you asked was the traditional relationships between the state programs as well as the research programs are more like the researchers driven, and how we can integrate the needs of the communities, organizations, and other underserved populations into research. Is that a question or not?
Yeah, can I try? So I think what I heard you say is you want to know about research in other programs, institutions that don't usually work with minority serving populations, and what we could be doing to help them get better working with minority populations. Is that what we're doing? It's hard to hear.
Thinking about, like, I think with state health departments, we notoriously worked with university-based research institutions that are harmful for our target population that are also experiencing disparities in maternal health. And so how we move away from those institutions, and those are the relationships that have been established previously, and more toward community-based or organizations, research centers that are more minority serving or who are focused on activities and don't have as large a history of harmful impacts on Black, brown, LGBTQ, post-disability population. Is that?
I think that's one thing that HRSA and federal agency moving to, because traditionally, a lot of the grantees are the large institutions, they have a lot of resources. They may not really link to the communities. And we are moving toward the direction that we want to engage more the non-traditional grantees, like for example, the minority serving institutions and community-based organizations. That's what this maternal health research network for minority serving institutions is due. And we try to support the minority serving institutions to have an advantage in the grant application. Also, I think it's a way for us to make our research more relevant to the communities. So that's the reason we want to build partnerships between researchers and the underserved population pilot programs for them to really understand the needs of the underserved populations. For every of our nobles right now, for the research networks, we ask them to partner, the researchers to partner with the underserved populations and also to engage people with lived experience and also partner with the community-based organizations. So their research can be relevant and really reach a population we want them to reach and conduct this better research that we want them to conduct. Did I answer your question?
Okay, well, if there aren't any other questions, I will, oh, we have one more. Oh, I'm sorry. Ellen, there's one in the back. Thank you.
Just really quick to kind of piggyback on that one, right? So I guess one of the things that we even on when we did our needs assessment is we work with community-based organizations and our local health and started on all that good stuff. But one of the missteps that that we didn't plan for is the creating translational products that will serve the organizations or the communities. So there was a lot of emphasis on publishing journals, going to conferences and whatnot, but not so much on like, okay, well, how can this organization use these things to improve their services, or can that be useful for a grant? Kind of supporting sustainability of grassroots organizations using these partnerships.
So that's right on the target, because we realized previously we asked the impact is how many publications to publish, but now we feel that's not a real impact, because when you publish something, that doesn't mean it will be translated into practice. Now we are looking more further about the impact of your research findings, and we are developing some materials for the researchers, some tools for the researchers to use. For example, the template for them to disseminate their research findings into various audience, either the government officials or the programs as well as the families. So we have realized that we are moving to that direction. So thank you so much for this comment.
Okay, well, thank you all for the questions, and I will hand it back over to Shirley to close us out.
Okay, well, we did really good job. We stayed we're ahead of time. We got 7 minutes, so we did good. Well, again, thank you everybody from the team that presented in MCHB. A special shout out and kudos to Erin. She's the one, the reason that we are and Ellen as well. We really appreciate you all. It pretty much ran on script, so I'm proud. Again, our biggest takeaways, like we know this was a lot of information, like especially around performance measures, like Carrie Ann mentioned. So please take the opportunity, take the time, read the guidance from beginning to end. Even if you got to read it a couple nights after you fall asleep the first night, just pick it back up. And read through that, because we do want to hear from you. We want to hear your comments. We want to see, what you have to say. And this is something that this version is something that we are very, very proud of and that we were able to put together. So please take a look at that. And again, please enjoy your time at the conference. Again, be intentional about reaching out and introducing yourself to someone that you may not know or stuff. And again, taking time to have lunch or a coffee or dinner with the people that you haven't seen for a while. So with that, I'll stop because I'm the only person stopping you from lunch. So have a wonderful rest of the day.